Hello everyone and welcome to today's webinar, Trauma's Verification's June Q&A web conference. For best sound quality, we recommend you join today's session using your telephone. You may have joined the presentation listening using your computer system by default. If you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. I would now like to introduce Molly Lozada, the Trauma Verification Program Manager.
Thank you. Thank you everyone for joining today's webinar. I'd like to introduce our staff for today. It's going to be myself, Molly Lozada, I'm the Program Manager for Trauma Verification, and Rachel Sanchez, who's the Site Visit Coordinator for Trauma Verification as well. Just a couple of things to go over. Continuing education. To qualify for CE, you must attend at least 15 minutes of the educational content. An email will be sent to all attendees who have qualified or who qualify for CE within 24 hours of the webinar ending with instructions on how to claim those. If you have any questions during the webinar, you may email us at cotvrc@facs.org. The goal of today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient, understand the processes and standards involved in an ACS trauma verification site visit, and how following these will positively impact the quality of care of the injured patient at your center. So with that said, let's get started. Just some things to keep in mind as we're going through the webinar: to have a copy of your resources manual. If you do not have a hard copy, you can download a PDF version from our website. The link is noted below. Along with the manual and the PDF, you want to make sure you have a copy of the most current clarification document and verification change log that are posted in the website as well. So those go hand in hand. Just a couple of things about the difference between the clarification documents and the verification change log. The verification change log will contain any changes made to a criteria, standard, or requirement. We use those words interchangeably. The clarification document may contain some of those changes early on, but the clarification document for future use will be used to clarify any standards that may be nebulous. This is just a screenshot of what the clarification document looks like. It's a little different than the change log. This is a screenshot of the change log. And again, you can sort the change log by level, by criteria, any way you like. It's in an Excel format. The recording of the webinar will be posted shortly after this, about a week, on the webpage. You can scroll down towards the end of the resources webpage and you'll have some links there from past webinars for some folks who had questions about where they're contained and where they're housed. They live on our resources webpage and they are towards the bottom, so you'll have to scroll a little bit to get to them. All questions are pulled directly from the questions submitted. There have been no edits made to the content of those questions. If your question is not answered today, the question may require more information and will receive a response from the ACS staff, or in some cases what happens is that we've had multiple questions regarding the same topic. Just a few announcements. I'm going to go ahead and transfer this to Rachel.
So the 2017 TQIP Annual Scientific Meeting and Training will be November 11th through 13th. This year it's in our Sweet Home, Chicago. Registration will open the first week in August, and you can visit the website for more information. The hotel reservations are open, and we recommend reserving your room early. Abstract submission closes at 11:59 on Friday, June 30th. So once midnight hits, it's closed. And you'll find more information at the link listed. There will be a variety of pre-conference workshops in which you can sign up for. Registration is open for some of the workshops, and you'll see some of them listed here. As you'll see, the AIS and injury scaling uses and techniques, topic, optimal course, AIS 15 updates, and you'll find a more detailed listing at that link listed there.
So thank you, Rachel. A couple of things I want to talk about is the resources revision process. We are underway with this process. If you've listened to past webinars, I did mention that we had started Chapter 6. We're pretty, it's hard to say we're done with it, but we are at the final stages of Chapter 6, and we're going to meet and discuss that process here this week. So the next chapter up for revisions are Chapter 9, which is orthopedic surgery, and Chapter 10, which is pediatric surgery. So for those pediatric trauma centers out there, whether you're standalone, slash freestanding, or combined with another trauma center, if there's anything you all want to see change or edited or modified regarding the standards, even if it's for clarity, please go to this stakeholder public comment website and just tell us if it has anything to do with the standards, you know, whether we need to make it just clearer to separate, maybe separate, you know, pediatric criteria versus adult criteria, because right now, as many of you know, it's kind of like assumed that the entire book is relative to a level 1 pediatric trauma center, or 2 with some additional components in Chapter 10. So anything you can give us to make it better for you all, and that's why we're doing this, to make it clearer and make it more helpful for trauma centers going forward, that would be greatly appreciated. And if there's anything that will be modified or edited or retired, we ask that you do provide us with some evidence-based information or any documentation that would support your decision or your choice to add, modify, or retire that. Following Chapter 9 and 10, which may be another couple of months while we work on that, we are going to move on to Chapter 15, which is registry, and that is the, as many of you are familiar with, we do have the registrar component in that chapter, so that would be ideally the time to go in and provide us some information on how you want to see changes made to those requirements there. And following that is going to be the chapter revision. I'm sorry, the research revision, I apologize. Just a reminder that I do have a new tutorial online, and this is for new trauma programs or even existing trauma centers that want to get an overview of our process and how things work here at the office, or how things will work for your site visit, beginning with where to find useful information, site visit application, the resources manual, clarification document, those sorts of things. This tutorial will definitely help you get to where you need to be to ensure you have a site visit and a successful verification visit following that. And that tutorial is available on the resources webpage at the link noted below. Some scheduling reminders. I'm going to go ahead and give this back over to Rachel.
So the applications for your site visit must be received in our office 13 to 14 months before your visit. This not only gives you plenty of time to prepare for the visit and complete the online PRQ, but it also holds your spot for the visit. At this time, we are completely booked all the way through June 2018, and there's just a few more spots available in July of 2018. And then the rest of the year is pretty open. The next few slides, Molly will go over.
Sure. So along with the site visit application, I just want to just remind you that there's additional documentation needs to be submitted with your application, and one of them is, and this is only applicable to level 1 and level 1 trauma center and level 1 pediatric trauma center, and a combined level 1 with a level 2. We need the orthopedic traumatology leader form. I know I've seen a couple of questions come through the webinar and emails that I get and Rachel receive about this OTL form. I realize it's an additional document to complete with the application, and that is for your orthopedic traumatologist to complete. We do have a running list. If you're in the 3-year cycle following the the release of the Orange Book and you're up for verification under the Orange Book, we may have a form already on file for you. If there was no change to your orthopedic trauma leader, I would definitely reach out to Anita at the COTVRC at facs.org just to ensure we have that information on file. We definitely should. We have a running list. And the other piece of this is that if you are a trauma center that has a non-board certified surgeon who trained abroad and will need to go through the alternate pathway for the very first time, you need to provide us that information on the site visit application. Just another more information about the OTL form. As I mentioned, if you did submit one, that's fine. We may have that on file. You can confirm that with Anita through the COTVRC. For those combined trauma centers, meaning a level 1 adult and a level 1 pediatric trauma center will be reviewed in tandem or at the same time, we only need one form. Actually, I'm sorry, we need one form completed entirely, and the other form just has to be just a summary. Questions 1 through 3 just have to be answered. And again, if for whatever reason you're having these separate, which is okay, you can have them done separately, we may have a form already on file. Again, you can verify this with Anita through the COTVRC at facs.org. So the alternate pathway, just want to remind folks what it essentially is. It's for those trauma centers that have a non-US or Canadian board certified surgeon or physician who trains overseas. This does not pertain to non-boarded surgeons who trained here in the U.S. It does not apply to them. It applies to those that trained abroad. And on the application, what we'll need is their name and their specialty and a copy of their CV. Again, for more information on what the criteria looks like and what is going to be required at the time of the site visit, please visit our site visit application website. That's where the alternate pathway criteria will be found.
Okay. So in regards to the PRQ online access, when your application is received in our office, you will get an email receipt and your PRQ logins will be in the context of that email. So you'll want to hold on to that email. The online PRQ can be accessed at that link, and also a copy of the PRQ in Word can be downloaded from the link listed. We ask that you please do not submit payment with your application because your center will be billed annually for the Trauma Quality Program fee. This does not include fees for additional reviewers if needed. At the link below, there's a really great fee structure with the fees for the next 3 years. We encourage you to view that. Scheduling a site visit. You should receive your site visit dates by 90 days before your scheduled visit, give or take, and ideally all visits will occur during your requested time frame. When the lead reviewer is available for your site visit, the trauma program manager will be contacted to confirm the dates. Okay, site visit preparation with the reviewers. Reviewers will book their own flights through the ACS travel agent, and they do this approximately like 30 to 20 days prior to the site visit. The hospital is responsible for the site reviewer's hotel accommodation as well as their ground transportation. You will have the reviewer's contact information once the full team has been secured, which is approximately 90 days before the visit. And also, please be sure to contact the reviewers directly within 30 days of the site visit to email their hotel confirmations, get their flight itineraries, coordinate ground transportation to and from the airport, hotel, and hospital, and any other site visit logistics.
And I want to just interject real quickly. One of the questions we get often is that at what point do you contact the site reviewers? And really, there's no, we have no time frame for that. But while you're doing all these, gathering all this information, this would be a great time for you as a trauma program manager, or even the trauma medical director, to go ahead and initiate contact with the reviewers just to go over any issues you think that may come up during your PRQ review. You know, and this way you can kind of have that conversation leading up to the visit. And if there's any additional documentation that they'll need in preparation for the site visit, you can go ahead and resolve that at that time. So I'll go over the focus review on-site preparation. It's been coming up a lot, people having questions on this. And there is a focus review agenda available on the web page that can be downloaded. And it's the format's a little shorter than the actual 2-day standard site visit. So for a focus review, we're coming in, or I should say the reviewers will be there the evening leading up to the site visit. In some instances, the reviewers will come in the day of the focus review if they are able to get a flight super early in the morning and make it to the trauma center about noon that day. But typically, it is the evening before that they'll come in and then start the review process first thing in the morning. So on day one, the initial reviewers will come in, and just for clarification, that you will get one of the initial reviewers to return and possibly have a nurse reviewer if we're not able to secure a second trauma surgeon reviewer. So just don't be surprised if you see a nurse coming along. It's acceptable to have that. So leading up to the site visit, we'll want a corrective action plan 30 days before the site visit. I do want to stress that we do not require you to do a presentation, but it's okay if you do, about the corrective actions and what was corrected. As I mentioned, the review will commence in the morning, usually about 700 a.m. unless you're told otherwise by either the ACS office or the site reviewers. That's why I mentioned that it's important to reach out to them at some point before the site visit, just to get some information on what their plans are. There is a chart review process that will ensue. That's the purpose of having an on-site focus review. And the chart review process is going to be basically focusing on the issues identified at the previous site visit. We're not there to look for additional CDs unless it's something that leads into the current deficiency. And then it's followed by a closed meeting and an exit interview. I do want to just go over really quickly the difference between a focus review on-site and by documentation, because I've seen some questions come up about that. An on-site focus review, as I mentioned, has to do with case reviews. That's the purpose of the on-site visit. By documentation, or by mail, as we refer to it here in the office, basically just means that we're asking for, it doesn't require a chart review. None of the requirements require that, but if you were cited anything to do with peer review attendance, CME, lack of CME, or something to do with the registry, anything that can be resolved by documentation is what we're asking for, and that's what it really means, is that you can submit that by documentation, and that's reviewed here internally and then reviewed by the team and then the chairs. So I'm going to go ahead and move on to general questions. So there was a couple of questions about the consultation, application, and the alternate pathway, and what the process for that is, meaning if you have someone who is pursuing the alternate pathway, what is the process, and do we need to do it at the time of a consultation visit versus a verification visit? We highly recommend having the alternate pathway at the verification visit, because that is when either they meet the standard or don't meet the standard, and in where a consultation visit, there's really, you'll have to pay for it at the consultation visit, and then you'll have to pay for it again during the verification visit. So we ask that the alternate pathway information is done at the time of the re-verification or verification visit and not during the consult visit. I had a question asking to clarify how the deficiencies and outcomes work and this actually goes to any trauma center seeking verification or re-verification. If there is a type 1 deficiency identified at the time of the site visit, you will not get a 1-year verification. You can get a type 1 deficiency with 2 type 2s or 3 type 2s. It doesn't matter. The type 1 just really does not permit verification for 1 year. If there is no type 1 deficiency, but you have up to 3 type 2 deficiencies, the trauma center will get a 1-year verification. In both of the scenarios I spoke about, a focus visit will ensue. And again, I talked about the on-site focus versus by mail, and that is going to be dependent on the type of deficiency that was cited. Typically, type 1 deficiencies would be if there was no neurosurgeon present or an orthopedic present, OR issues or delays in OR, things like that, which are significant. Your type 2s are more your peer review attendance, not, you have some surgeons that are not attending peer review, et cetera. There's a list in Chapter 23 that identifies what these categories are. PRQ, I had brought this up last month and there was a typo and I apologize for that, or this is more clarification. So tibial washouts, in the PRQ, the question is the average time to wash out of open tibial fracture secondary to a blunt mechanism. We just want the average and the range. And really what we're looking for is the time to the first operative washout of open tibial shaft fracture when the patient presented in your ED, and that is within 24 hours. I believe I had said an hour, and that was for antibiotics. This is for the tibial washouts, it's within 24 hours. I just want to make sure this was clarified. PRQ, I had a question about can an ED discharge, such as an ankle fracture, who were subsequently admitted via assessment for surgery, be counted in the numbers in the PRQ? Well, this is going to depend on the trauma center and their admission policy. So if the center includes the isolated foot and ankle injuries and it meets the NTDS inclusion criteria, it should be captured in your trauma registry. Of course, if you're some states don't want that, or some of your local authorities don't do that, that's okay. The question is pertaining to this particular person. If the center includes them in the total number of trauma patients admitted on the PRQ, then you must follow the rules as any other trauma admissions, such as reviewing non-surgical admissions on page 121. So it goes through a series of how to review your non-surgical. So again, if ankle fractures is not part of your admission criteria, that's okay. And if it is part of your admission criteria, then there is a process to capture those in the registry. Couple of questions about the tables in the PRQ. I know we've done a couple of changes in what we're asking for, and hopefully we can clarify that here. In the section, this is actually in section 2 of your PRQ. It's under the description, trauma level and rows. The table related to total number of ED visits refer to all ED patients. This is a great question. Megan and I get this question quite often, and we're working on addressing how to make that clear, and we hope we did do that in the latest version of the PRQ if you're working in it. So the answer is no, it does not. It really, what we're looking for is those patients seen in the ED for trauma that were admitted, and it's regardless of the service. So it's ortho neuro, but it actually met trauma inclusion criteria. So Table 5, data field label, admitted ED trauma visits, regardless of service, which is your first line, your first data line, should contain the number of trauma patients that were admitted from the emergency department So we don't want you to include all your hospital visits. That number would be huge, and the next slide is going to demonstrate why that is. Actually, next 2 slides. So table 6, same situation. It doesn't include all ED dispo for all trauma patients. So the table 6 disposition is for those trauma patients that were admitted who met the NTDS inclusion criteria. Tables 5 through 8 and number 11 must match as depicted in the following slide. So here's what the tables look like. We did some color coding to make sure that the tables all match where they need to match. And as you see here, the first line item on table number 5, it says admitted ED trauma visits. We want admitted trauma ED visits, not all trauma visits. So this is actually a great picture to show how the numbers should all correlate to each other and how they should match. If there is a discrepancy, which there's an allowance to have a discrepancy, there is a data field also that for whatever reason, if you don't include your direct admits or or maybe some pediatric patients that got transferred because it's an adult-only trauma center, you can definitely provide us some documentation to say why there's a discrepancy. But we definitely need them to match, and if they don't match, it's okay, but you have to give us and provide us a response as to why they don't match. Death, hospice, should we be entering a patient as a death or as a live if discharged to hospice? So for verification purposes, if the hospice patient was still alive when they were discharged or transferred, it would not be counted as a death case. If the center receives information following the patient's death, then you may count that as a death, or actually review that through your PI process if you like. Self-reporting, trying to track when surgeons see admitted trauma activations. Is it acceptable for them to document examine patients at time on date, or is that considered self-reporting? Well, it is self-reporting, and it is acceptable to self-report. What we like to see, or what the reviewers like to hear at the time of a site visit, that if they are self-reporting, that there is a process or a mechanism by which you can validate this information, or somebody is validating this information, like a nurse scribe, or there's a badge scanner, whatever the process is. I mean, this varies by trauma center. Physician assistant evaluation. Can ATLS certified surgical PA respond and complete an initial evaluation for a trauma modified or consult patient? And I will say that trauma modified to me here means it's one of the tiers, like the second level tier. It's not your highest level of activation, but your second tier, maybe it's called modified, and the consult level. So for the physician assistant, they may respond and provide initial evaluation for the limited mid activation tier or consult level that's appropriate. For the limited activation tier, the PA must be current in ATLS because they're responding to an activation. So you can refer to CD 1186 in previous webinars, and I believe I have one here as well. Question is, if the PA is able to complete the initial mod consult evaluation of a trauma patient, are the trauma surgeon standard response times for those tiers able to be delayed or deferred if the patient is to be transferred? Obviously, with the understanding that the transfer would not be delayed waiting for the surgeon under normal circumstances. I agree with that. You never want to delay transfer. If your patient is stable and the transport is present on site, but you're waiting for the trauma surgeon to come in, you don't want to delay that care. I agree with that. If the PA is providing initial evaluation for the limited or consult tier, there must be communication with the attending surgeon prior to the patient being transferred. Important. Transfer of a patient should not be delayed while waiting for the attending. This practice is not an excuse for the surgeon not to respond. These instances must be documented and reviewed through your PIPS process. So we're going to move on to CD-related questions. Pediatric patient admission, again, just another clarification for verification and completion of the PRQ. The patient age is defined as less than 15 years of age and who meet the NTDS trauma inclusion criteria. Your local and or state inclusion measures may differ and require the center to capture a different set of patients and criteria. And again, that's for any states that have their age set at possibly 17, 18, 22. That's okay. However, when you're completing the PRQ, the data that is going to be used is just for those patients that are less than 15 years of age. That's the data that we want to capture. Transfers. Are patients that drive themselves from an outside hospital considered transfers, even if arranged by the physicians? No. These patients would not be considered transfers into your facility. The transportation method must meet the patient's needs, equipment, and all care providers on board. And ideally, you want to maintain continuity of the patient's care. So if they're driving themselves to your facility, it's not a transfer in. It's going to be probably a direct admission depending on the injury. Hospital and medical staff resolution, had a couple of questions about this. Chapter 5, Table 1, if you go to the resources book, there's a nice little grid there that has the hospital's commitment, and then there's a couple of subject headings there for medical staff resolution and liaison, physician liaison commitment. The question is that good until the liaison resigns, and must it be renewed every 3 years? Well, currently the standard is for hospital commitment and medical staff resolutions to be current every 3 years at the time of a re-verification or verification visit. So you can have a separate physician liaison commitment that may be incorporated into your medical staff resolution, but it's not, per the standard, it's not required at this time. So again, you can incorporate that into either the medical staff or the hospital commitment letter, but it's not required. Ideally, if there's a change in your liaison, you want to definitely capture that somewhere in your physician liaison commitment document. Criteria for graded activation. What are some examples of geriatric specific trauma team activation criteria? So this has been coming up pretty much at every webinar, and I do want to let everyone know we are working, as part of our revisions process, we are working on developing a geriatric chapter. We have not started that yet, but these questions definitely will help in our process of developing that chapter. So at this time, we do not mandate geriatric-specific criteria. However, if the center sees a high percentage of these patients, it would be the expectation that there are geriatric-specific activation criteria and guidelines, and they can be incorporated into your general activation policy, and maybe just a separate section. Some examples of what it may contain, it may be falls above ground level, you know, in greater than 65 years of age, traumatic mechanism in a patient with known bleeding disorder or use of anticoagulant and antiplatelet medication. So these are just a few examples. You, as a trauma center, you can develop your own geriatric criteria. Just be advised that at the time of the site visit, the reviewers will are going to ensure that you adhere to your own standards. Again, just a quick overview of the alternate pathway criteria. This is, again, just for trauma surgeons who trained outside of the United States or Canada that may participate in the trauma call panel if approved by the alternate pathway. There's a link on there that you can go ahead and look at the types of alternate pathway we have. And I do want to stress that only surgeons who were inducted as a fellow of the American College of Surgeons prior to January 1st, 2017 are exempt from the APC. So the new change is that if they were recently inducted into as an FACS, actually are going to recently be inducted as in October of Clinical Congress, they would have to go through an on-site alternate pathway review. So for surgeons who were previously approved at the facility that they're at, an on-site review will not be required. However, they are going to, or the reviewers are going to ensure that there is a performance improvement assessment by the TMD to ensure that patients' outcomes compare favorably to other members of the trauma panel. So that'll be done on-site they'll have to meet the same requirements as all the other trauma panel members. So therefore, if there's any U.S. or Canadian trained surgeons who were never or not currently board certified, cannot be reviewed by the alternate pathway, and these are U.S. trained physicians and trauma surgeons. Emergency physician ATLS, need to clarify the ED physician who is board certified but not current in ATLS. It was cited as a weakness on our last visit, so what will we need to do for our next visit? Without knowing the specifics of the site visit, the current standard is that if the physician who is working in the emergency department was boarded in emergency medicine, they're not required to maintain current ATLS, but must have taken it at least once. For physicians who are board certified in something other than emergency medicine, such as internal medicine, family practice, a pediatrician that is covering your ED department, they have to maintain current ATLS. That is the standard, and this physician would be required to maintain current ATLS. Neurosurgery, the neurosurgeon employs a hospitalist who functions like a PA or NP for them. This MD rounds on their inpatients. Can this physician see the consults initially? The Orange Book allows for mid-levels that work under a neurosurgeon. Please advise. Yes, it is acceptable for the hospitalist, the physician assistant, the advanced practice providers, mid-levels to respond to the neurosurgical service. In this instance, or in this case, there must be agreed upon guideline between the TMD and the neurosurgeon liaison for the types of injuries the hospitalist, PA assistant, or APPs will respond to as a consult, and there must be clear documentation with the attending specialist, neurosurgeon, on the plan of care for that patient that they're consulting on. Orthopedic trauma leader, OTA fellows, all my attendings completed their training prior to 2013. Peds Ortho MDs completed a Peds Ortho fellowship, not an OTA fellowship. That seems more adult focused. How are we supposed to be compliant with this rule? Great question. I covered a little bit in the opening slides about the OTL form and how what we want. And this person is correct. There is not a pediatric OTA fellowship, but what there is, what the Orthopedic Trauma Association has, they have a list of fellowships done prior to 2013 that are technically grandfathered in. We, the VRC staff, do not have that list. That's why we ask for this form to be completed. That form goes through a series of reviews by the OTA subspecialists that we have as members of our committee, and they are the ones that kind of ensure that the fellowship was in compliance with their requirements. So for pediatric programs, there is not an OTA fellowship. Therefore, this requirement may be met with a formal transfer agreement, or in some instances, which we're seeing more of, is that the OTL leader is shared with an adult trauma center. So that means the OTL leader from a level 1 comes over and does cases, or maybe you transfer cases to the OTL leader. If you're sharing the same OTL, then we definitely want to have that information and would want you to comply with the OTL form that we're asking for you to submit. So again, refer to the slide earlier in this webinar. Massive transfusion protocol. Review of MCP requirement. Will ACS only accept 1-to-1 ratios, 1-to-1-to-1 ratio? We do not have a defined ratio for massive transfusion protocol. I know this is typical. It's not a standard, but it is something that we see over time, that the ratio is 1-to-1-to-1, but it's not required, or nor do we have a standard for that. Advances provider. Practice providers, does the NP meet requirements for timing when a patient is seen by admitting team in limited tier activation? It's worded a little awkward, but it is acceptable for the nurse practitioner to respond to the limited tier activation and provide assessment or interventions to trauma patients. In this scenario, the NP must be current in ATLS, and again, nurse practitioners, mid-levels, advanced practice providers, hospitalists that are providing this type of care for the limited tier activation, it is appropriate for them to do so. We just ask that they be current in ATLS to meet our standard. Burn patients, CD 14-1, CD 14-1, can it be included in defined process for which patients will be transferred, or do we need a legal transfer agreement? The center must have a written transfer agreement. That is the standard. It does ask for a written transfer agreement or contract. I put in here some centers call it different things. Some centers call it a policy. We really don't have, you know, an exact verbiage, but we're asking for some type of agreement between the trauma center and the burn center that will be receiving those referrals. Trauma registrars. Can a hospital system place all registrars together to work in multiple registries as a separate cost center from trauma? I had a couple of questions about this. The second question was, is the registrar requirement per 500 to 750 admissions on or per registry entries? So I will say that depending on the budgetary process, it's going to differ from many trauma centers. We're not looking at cost centers when we come and do a site visit. Ideally, we'd like to see that there is a budget line for trauma and how the registrar reports in the budget. We're not looking at that, but the requirement clearly states that there has to be one FTE, one full-time equivalent employee dedicated to trauma. So again, we're asking that this person, if it's going to be a group of registrars, trauma, cancer, any other type of registrars, there has to be one dedicated registrar for every 500 to 750 admitted patients annually. So for the person who asked whether it was based on admissions or per registry entry, it's based on admissions at this time. As I previously mentioned, that we will be looking at Chapter 15 for revisions. If there's any issue with the standards or any edits you'd like to see or any modifications done to this particular standard, I highly encourage you to visit our Stakeholder public comments website for to provide that information so that we can appropriately make the changes needed for trauma centers. Question on registrar. We are a level 3 trauma center and enter greater than 800 patients per year into the registry. Our administration recently laid off our trauma registrar, and the plan is to have multiple staff from our PI departments enter the trauma data for us. From what I read, this results in a level 1 or 2, that's a type 1 or type 2 deficiency, and prevent us from being completely verified. Can you comment? It's a great question. I think we're seeing this over time. We're seeing this in a lot of programs. This is a level 3, and hopefully I'm going to answer this for, my answer will help level 1, 2, and 3 trauma centers, but ideally this response is for the level 3. This may potentially be cited as a type 2. It's not a type 1 deficiency. It's a type 2 deficiency at the time of the site visit. It may not necessarily keep the center from achieving verification. So as I previously discussed, the outcomes and the type of deficiencies, if this is your only CD, the trauma center will receive a 1-year verification. So again, refer to the slide on deficiencies and outcomes. As the requirement states, there must be one FTE for every 500 to 750 patients admitted annually. Having greater than 800 patients admitted into the registry will require 1.5 FTEs to comply with the standard. Again, it's 500 to 750. If this trauma center is seeing 800, that's about 1.5. And this, because it's a level 3 trauma center, the trauma program manager may kind of fill in the 0.5, but you definitely need one FTE for every 500 and 750. If other staff, and what I wanted to say about this is that if you're in a program that is looking to do this, have other people who are not trained as registrars do this for you, there is another requirement that these staff members will need to have training. They need to have 2 courses within a year of being hired or of their new role. and that is the American Trauma Society's Trauma Registrar course or an equivalent provided by the state program. And the second course will be the Association of Advancement of Automotive Medicine's Injury Scaling course. So along with having these other people do the trauma registry data entry, they're still going to be required to meet the same standards as a registrar. Core measures, question on core measures. PI core measures, do we have to report all the findings to either peer review and or systems, or can we report by exception? By exception, attending arrival times below 80%, increasing the incidence of VAP. So all core measures established by the program, because you establish what those core measures are not required to be reported out. However, if there are any core measures that result in an opportunity for improvement, there's issues that you've identified, there must be a process to review, document, and report out as part of your hospital's PIPS plan. So if there's an issue identified as part of your core measures, that should definitely be reviewed by the peer review or the systems. It doesn't have to be reviewed by both, but if it's a systems issue, definitely report out to the systems. If it's a peer review issue, you want to report out to the peer review. Mortality reviews, hospice discharges. Our hospice discharge is expected to go under the same review process that an expired patient does in the trauma program. Example presented at M&M for review meeting. If the death, and this is what we're saying about hospice, and I know it's been coming up a lot here recently, if the death occurred while under the hospice care at your facility, then that case will be reviewed. If the patient is transferred to a hospice care facility, those cases will not be reviewed as part of the death case. We're not saying they don't have to be reviewed, but if you receive feedback from the hospice facility that the patient has deceased, you can definitely review that case as part of your review, death review. So you can do either. You can, or if they didn't die in your service, then they were transferred to a hospice, so they don't need to be reviewed. Peer review of combined centers. Can you clarify the pediatric level 2 centers that care for adults? Do all adult trauma surgeons need to attend the pediatric peer review meeting, or can there be a designee from the adult group that attends? Yes. So it's a great question. This was actually a recent change, and it is in the clarification document. We clarified this a little bit more. There may be a designated member from the adult panel that attends a pediatric multidisciplinary peer review meeting, and vice versa. Ideally, it should be the adult trauma medical director. However, it may be another member from the adult panel. Meeting information must be disseminated to other adult panel members. And as I said, this can be flipped around for the adult level 1 with a level 2 pediatric program, that all members don't need to attend the others meeting. Ideally, it would be great, but it's not required. What we're asking and what the change is that if you are a combined program, that someone from the adult panel attend the pediatric meeting and someone from the pediatric panel attend the pediatric meeting, and vice versa. I'm sorry, I may have confused that. So adult member attend the peds, and the peds member attend the adult meeting. Nursing education. At a recent verification visit at one of our sister hospitals, they were told the nurses needed 8 hours of CE yearly. Is that not the case? That is not the case. We do not have requirements for nurses requiring CE. What our requirement holds true as of today in the Orange Book is that a level 1, 2, and 3 trauma center, there must be a mechanism to offer trauma-related education to the nurses involved in trauma care. Currently, the VRC does not hold a requirement for nurses to maintain CEs. I will say that the trauma program manager is an exception. That person is required to have CEs. However, for the other nurses caring for trauma patients, what we're asking is that the trauma center allows them or provides trauma-related education to them, but we have not defined a set hours of CE for those nurses. Alcohol screening tool. Is there a preferred required substance screening tool? whether it's SBIRT or CAGE, is there a preferred required tool for pediatric patients. There is not a preferred tool to screen for either adult or children. We provide a couple examples in the PRQ, or a couple of options in the PRQ of what you can use. There is another area where if you're using something other than what is there, you can definitely do that and just provide us a description of that and the PRQ. So the institution would define which tool works best for its patients. And alongside that, if you're a pediatric trauma center or adult trauma center that also treats children, you do want to define the age for that, for when the children will be screened. We do not have an age for that, but we allow the institution to go ahead and do that. Research discipline. So this is a great question, and it's pretty wordy. So basically, in the PRQ, there's an additional question whether there is one article from 3 of the 6 disciplines, but of the 20 articles, 4 of the 7 scholarly activities are demonstrated. Is there at least one article with authorship or co-authorship from 3 of the 6 disciplines? So there's a list of disciplines that's permitted. The PRQ does differ a little bit from the actual manual, and we are definitely working on addressing that with our programming, so we will fix that. Below, there is a discrepancy, as I mentioned, and it's pending programming. I will say refer to the resources manual and the clarification change log documentation for the following disciplines, because we just added acute care surgery to that list that's not in the manual. So what we will permit as the additional, what is permitted for authorship and co-authorship is basic science as related to injury, neurosurgery, emergency medicine, orthopedic, radiology, anesthesia, vascular surgery, plastic, maxillofacial surgery, critical care, cardiac thoracic surgery, rehab, acute care surgery, and nursing. And so again, this is not in the PRQ, so I realize that's a little confusing, but please, if you have any questions about that, feel free to reach out to Megan or myself through the COTVRC@FACS.org inbox, and we'll go ahead and help you through that. But we are going to work on this to fix this. So just a couple of things about CME. I do want to bring this around. CME, ICU intensivist, and hospitalist, after further discussion with the VRC chairs, and this just occurred this week, the following would be provided to all trauma program participants and site reviewers in my next monthly update. If the intensivists are the primary physician responsible for the care of the patients while in the ICU, patient care is transferred to them. They are required to maintain external CME and or through an IEP process. There were a ton of questions about whether or not, if they're an intensivist, they're only there to manage a component of that trauma patient, whether or not they needed to meet CME, and I know I have instructed folks that they do. We have had many discussions on this, and we have officially provided this this clarification, and again, this will be in the clarification document in the next month. The VRC does not presently hold a requirement for hospitalists to maintain CME. As I mentioned, this will be noted, and it will go out to all trauma program participants and site reviewers so they are aware of this new change. So that concludes my webinar today, and I'd like to thank you for participating.
And thank you. Thank you, Trauma Verification staff, and thank you, everyone, for attending today's webinar, Trauma Verification's June Q&A web conference. If you have any other questions, please contact COTVRC@FACS.org. And on behalf of Trauma Verification and our presenters, thank you for joining us today, and have a great rest of your day.